Iliotibial band syndrome, or ITBS, is one of the most common causes of pain on the outside of the knee, especially among long-distance runners and cyclists. The pain results from inflammation where the iliotibial band, a thick band of tissue running along the outside of the thigh, rubs against the lateral femoral condyle during repetitive knee movements. This syndrome can affect up to 12% of all running-related injuries and is even more prevalent in cyclists. Risk factors include pre-existing ITB tightness, high weekly running mileage, repetitive track use, and muscle weakness in the hip and knee. Understanding the anatomy and mechanics behind ITBS is key to both prevention and effective treatment. In the next scene, we'll explore the specific anatomy and biomechanics that contribute to this condition. Iliotibial band, or ITB, is a continuation of the tensor fascia lata muscle with contributions from the gluteal muscles. It runs down the outside of the thigh and attaches at several key points, including the lateral border of the patella and Gerdy's tubercle on the tibia. The ITB is free from bony attachment near the lateral femoral epicondyle, allowing it to slide during knee movement. Sliding is essential for normal function, but can lead to pain when repetitive motion causes friction or compression. Biomechanical factors such as weak hip abductors, increased hindfoot aversion, and excessive knee flexion during running can increase ITB compression. Training errors like sudden increases in mileage or frequent downhill running also play a significant role. Next, let's look at how ITBS is diagnosed and what symptoms to watch for. Diagnosing ITBS is mainly clinical. Patients usually report sharp or burning pain on the outer side of the knee, often triggered after a certain running distance or when running downhill. The pain can sometimes radiate up or down the leg, making it hard to pinpoint. Physical examination may reveal tenderness over the lateral femoral epicondyle, especially at 20-30 degrees of knee flexion. Special tests like the Noble compression, Ober and Thomas tests help confirm the diagnosis. Imaging is used primarily to rule out other conditions. Prevention focuses on gradual increases in training load, strengthening hip abductors and core muscles, stretching the ITB, and optimizing running mechanics. Proper footwear and avoiding repetitive use of sloped or uneven surfaces can also help. In the next scene, we'll cover treatment options and expected outcome. Treatment for ITBS typically starts with conservative measures. The acute phase focuses on pain control using rest, anti-inflammatory medications, corticosteroid injections, and myofascial release. As pain decreases, stretching and strengthening exercises for the hip abductors, gluteal muscles, and core stabilizers become central. Foam rolling and manual therapy can help reduce ITB tension. Gait retraining is essential to correct biomechanical flaws. Most patients recover with these methods, but if symptoms persist after 6 months, surgical options may be considered. Procedures include ITB lengthening, bursectomy, and arthroscopic techniques, with most patients returning to sport within 5 weeks to 5 months post-surgery. Rehabilitation after surgery mirrors conservative treatment, emphasizing gradual return to activity and ongoing muscle strengthening. With proper management, the outlook for ITBS is excellent.